We have Dr. Rodgers here today. Dr. Rodgers is the director of Pediatric Surgical Epilepsy, and we are very lucky to have him. So if you give him all your attention. And Dr. Rodgers, will you like to answer questions throughout the talk, or should we leave them till the end?
There's a lot of participants. I'm not sure I'm going to keep up with the questions as we go. Maybe we'll save them to the end. I know last time it was like rapid fire.
Yeah, very active chat. Okay, we'll save them to the end. So just put your questions in the chat and we'll get to them.
I am going to say, share my screen. Usually it's just the 3 dots here by our name to share screen, no?
Yeah, on the bottom of your screen, it should say share screen. It's like green. Do you see that?
Yes. This one. How is that?
Perfect. We can see your screen.
Perfect. Excellent. Well, welcome everyone. Nice early start for some of you, afternoon, I guess, for some others. It is 9 a.m. here in New York, and welcome. Hopefully this will be a little introduction to pediatric neurosurgery. I know in years past, people have really enjoyed this, and really it's going to be a broad overview, plenty of questions at the end, and hopefully really give a flavor. I know everyone is really in different aspects of their training, all the way from undergrad into residency. So hopefully we have a pretty good level of presentation here. I am in New York. I am the director of pediatric surgical epilepsy here at Northwell Health. That is a big system, and we'll go over a little bit of what that means. And hopefully you guys can gain a lot out of this. I know these lectures are really, really fun for everyone out there. I have no disclosures, but please don't reproduce any of the content here. A lot of this is sensitive pictures, and we're very privileged to be able to share this with you. But please don't copy it. Please don't screen save it. Please don't share it out there. Otherwise, we don't get to do this. So I come through my undergrad was Franklin Marshall College, and then at Georgetown Medical School in Washington, D.C. I then trained at NYU and the Bellevue Hospital, one of the oldest historied hospitals in the United States, is really where a lot of my training happened. And then I did pediatric neurosurgery fellowship at Ann and Robert Lurie Children's Hospital in Chicago. So I've been around, and I've been doing this here at Northwell for now 7 years. So I guess I would be considered a mid-level attending at this point, and hopefully I've seen quite a bit of stuff that I can share with you guys. Oh, where are we going here? There we go. So our main hospital is Stephen Alexander Cohen Children's Hospital. We are one of the highest ranked neurosurgery hospitals in the United States. For U.S. News and World Report, it is a full-fledged children's hospital that has all the bells and whistles of being a children's hospital. And I am very fortunate, I think, to work here, and I think our patients are really fortunate to get cared here. This system, though, that transfers essentially the pediatric neurosurgery care into one main hospital, that children's hospital, is huge. This has a huge amount of community hospitals, other affiliated hospitals, a ton of urgent care centers, physician practices. You can see here, this is a map of Staten Island, Manhattan, the Bronx, Westchester, Long Island. It is a huge, extensive metropolitan area, as big as some other countries out there, and really millions of patients that really get filtered down for pediatric neurosurgery to pretty much one hospital. That is the Cohen Children's Medical Center. I also, though, I work at Lenox Hill, at Long Island Jewish Hospital, North Shore University Hospital. There is a smattering of cases all over the system. These are my main spots, but really the pediatric care that I take care of is here at the Cohen Children's Hospital. This is always a very special lecture for me because when I was a medical student, I rotated with John Bookvar, And then when Randy was a medical student, he rotated with me. And it has been just a really special sort of timeline for me to be sort of in the middle of this, because it's such a privilege to be here among all of you, as Randy's been such a great organizer of this. And I really feel this like lineage sort of going forward. So really, it's a very special lecture to be here. And I'm very privileged to be able to talk to you guys. So what is pediatric neurosurgery? Wikipedia would say it's a subspecialty of neurosurgery. That's pretty obvious, which includes surgical procedures that are related to nervous system, the brain, the spinal cord, that treat children with operable neurologic disorders. Clearly, we operate on lots of aspects of the body, and we operate on the nerves, the brain, the spinal cord. I would even say now it's a lot more of the bones. We also do scoliosis. We're not doing as much hand surgery, elbow surgery, or shoulder surgery like the orthopedic surgeons, but it really, pediatric neurosurgery brings us to a lot of different locations of the body. And really the founder, so we think of Harvey Cushing as sort of the founder of neurosurgery in general, but the founder, we would say, of pediatric neurosurgery is probably Frank Ingram. 1929, he established the first pediatric neurosurgery service at Boston Children's Hospital. He exclusively wanted to care for children and really was the pioneer in this field. He had the first textbook. He had the first practice. He really sort of sparked this interest into specializing in children because they had really different types of diseases out there. So if anyone's going to be called the founder, the father, the sort of patriarch of originally creating pediatric neurosurgery, Frank Ingram's probably the person. There's been a lot of people since then, but still it is a very small field, extremely small. There's about 50,000 neurosurgeons in the world. There's about 2,300 pediatric neurosurgeons, and there's only 300 pediatric neurosurgeons in the United States. You can see that we treat a ton of diseases. So anyone under 18 with some of these diseases we're treating. So it's a very big, varied practice. We do brain and spinal cord tumors. We do epilepsy surgery. We clearly do a lot of trauma of the brain and the spine. We have skull abnormalities, such as craniosynostosis, congenital brain malformations like Chiari's, hydrocephalus, which is sort of like water on the brain or water building up in the brain, Spina Bifida, that can be in a very varied situation, open spinal cord defects and closed spinal cord defects. Now we also do some of the scoliosis work that our orthopedic colleagues were doing. We also do vascular brain and spine malformations, peripheral nerve injuries and brachial plexus injuries, sort of like birth injuries. And really, this is what attracted me so much to pediatric neurosurgery, because in adult neurosurgery, usually you get really pigeonholed into sort of doing, I'm a brain tumor surgeon, I'm a vascular surgeon, I'm a spine surgeon. And really, pediatric neurosurgery, you still get to do a lot of the sort of varied procedures. And really, it sparked my interest. You can see here in the top two slides, let's see if this pointer comes up. Top two slides, you can see a brain tumor at the skull base. This is a sagittal MRI. This is a coronal MRI showing that big, huge, sort of lemon-sized tumor pushing on this child's brain. You can see in the bottom left corner a spinal fusion operation for a dislocation injury. You can see the hardware going in. You can see here in the middle tile the epilepsy surgery grids that we used to place and the depth electrodes to monitor for seizures. And then you can see here on the right panel a big clival mass that's pushing on the brainstem, evading into the nose. And this is a clival chordoma that we resected through the nose. And really such a very different aspect of the brain and the spine that you get to see here in pediatric neurosurgery. Brain and spinal cord tumors is one of the big things I focus on. I do a lot of the brain and the epilepsy work, brain tumor work and epilepsy work. This is a huge skull-based tumor, a giant cell tumor that was invading into the skull base and pushing that temporal lobe clearly to the other parts of the brain. This here you can see, this is a brain tumor that came out on the left panel. You can see here on the right, this is a low-grade tumor that really you're looking at what looks to be normal brain, but hidden underneath that cortex is a low-grade tumor that looks very similar to other parts of the brain, but is really a major problem. We also do brain tumors through the nose, something called craniopharyngiomas or pituitary tumors. This is one of the big aspects that I focus on through the nose in pediatrics. 15 years ago, this was really sort of frowned upon, saying that the nose was too small, that the bone was too thick, that we couldn't really do this through the nose. And really, we've been pioneering a lot of these endoscopic resections through the nose to go near the pituitary to really cure children of these really technically benign tumors, but very locally invasive tumors. And these are all operations with our ENT colleagues that we sort of do through the nose, sort of scarless incisions. I also pioneer a lot of the robot use for epilepsy here at Northwell. We do a lot of the 3D planning with 3D modeling. We do robot use where we actually create models and try trajectories to really take care of some of the tumors here. A lot of that's also in epilepsy. This is one of our biopsies and 3D planning for sort of printing and using to teach as well as to navigate into the brain to biopsy some of these tumors. This one is a brainstem tumor, what we now used to call a DIPG, but now is called a midline glioma, and now also H3K27 tumor. A lot of the tumors now that we do have really become less named after a person or named after a location and really based on their biology, based on the molecular signature of these tumors. That's really how we're starting to name a lot of the tumors in medicine these days. Epilepsy is a clear, huge focus of what I do. This is the ROSA robot. There's a few other robots. I'm not endorsing any of that, and I have no disclosures for them, but this is the robot that I use to place a lot of the electrodes into the brain. I place laser fibers into the brain to burn tumors or burn epilepsy foci. Here on the right panel, you can see a catheter going into the brain, a laser catheter into a hypothalamic hamartoma to create a disconnection for gelastic seizures. That's seizures that cause a child to really laugh out loud repeatedly throughout the day. It can also cause precocious puberty. And you can see 3D modeling here, sort of practicing that arm. And really, this has been one of the best things. I had never done any of this before I became an attending. I'd never done this in residency or fellowship, and really was sort of one of the new technologies that was emerging. And now we use this almost every single week in the operating room. It really is an amazing piece of equipment and really fortunate for our patients to have. Epilepsy is a huge portion of childhood care too. The US incidence is about 150,000 per year. 1 in 26 people will develop epilepsy at some point in their life. 1.3 to 2.8 million people is a prevalence, and about 45,000 American children under the age of 15 are going to develop epilepsy. About 20 to 25% of epilepsy will be medically refractory. That's probably pushing that up to even 30% at this point. We have amazing medications for this, and if you can be on one medicine and have no side effects, that's the perfect treatment. However, there's a lot of children out there that need actually a surgical procedure to cure them of their epilepsy. And we do all those. I am very fortunate to have every technology you can possibly see in the world. We do laser treatment, we do robotic treatment, we do big open operations like hemispherectomies, we do laser operations, excuse me, and I really think we provide some of the best pediatric epilepsy care that can be in the world right now. And I think you guys will get to see a little bit of taste of that here. This, hopefully the video plays for you. This is our planning station. All these bright colored lines are electrodes that are going to go into the brain, and we're planning out to space them out to make sure we hit certain targets in the brain and really focus on where the epilepsy might be coming from. This patient needed to be on both sides of the brain. Are we going to get a video? Yes. You can see here we're planning the trajectories. We can plan to make sure we're not crisscrossing leads and that we're really hitting the targets that we want. This has saved us a tremendous amount of time in the operating room to be able to pre-plan some of these, and really the accuracy of this is incredible. You can see this is a 3D model of the CAT scan preoperatively. You can see the nasal cannula in the child's nose. You can see each colored electrode. And then based on these electrodes, the recordings will either find the seizure, we won't find the seizure. We sometimes have to add additional electrodes, which is rare. But usually we're able to then fine tune a really specific treatment to cure these children. This is one of the operative videos. This is the robot here. This is me on the left. This is us placing electrodes into the brain. You can see the robot arm brings us to a trajectory. It's sort of like a bow and arrow. So we register the face using lasers. That arm is the same arm that puts together cars. And then after that registration, we have our pre-planned procedure. The robot arm sort of gets us into a trajectory. It's sort of the bow and arrow being held, and then we're the ones pulling back and throwing the arrow. So not fully automated yet. I'm sure in the future that one day might be the case. But you can see here us placing the electrode, drilling through the skull, burning the dura, the covering of the brain, all our electrodes going into different aspects of the brain. And really, this is going to let us have supreme accuracy, but also be minimally invasive. These children wake up an hour after their procedure and they're eating lunch. It's really a unbelievable procedure where in the past we used to do big open craniotomies, and those children then would be days in the hospital, really in pain. There could be CSF leaking. This has totally revolutionized the post-operative experience for these children. That robot we also still use to place electrode fibers into the brain. You can see here on the left panel, that black line is going to a hypothalamic hamartoma. You can see then the patient's in the MRI suite, and then under MRI guidance, as the MRI is running, we're running heat maps in order to specifically burn that exact location where the hypothalamic hamartoma is connected to the rest of the brain. By disconnecting that generator of the foci of seizures can no longer work, and we sort of stop the seizures and usually cure these children. You can see here, this is the heat map. We have a representation of the brain. This is live heat map. This is actively, MRI is running through slices. We pick areas that we don't want to get hot, our low thresholds. We pick areas that we want to make sure that don't get too hot in the center of the fiber, so we're not vaporizing the brain tissue. And we have then a very specific controlled burn, and we know that the exact area that we want to burn and destroy is going to come out. And on the postoperative MRI, we know exactly what it's going to look like before. We also in epilepsy surgery have a very new device. This is only available in the United States. It's called a NeuroPace. It's a responsive neurostimulator. This is essentially an ICD. So for the heart, we think of, oh, we have a arrhythmia. Once that arrhythmia starts, the pacemaker or the ICD shocks the heart and gets it back into a rhythm. This is a very similar procedure where we put electrodes into the brain. We watch for seizures. When the device sees a seizure happening, it then sends an impulse into the brain to stop those seizures. And it's responsive, so it's watching an EEG, the brain waves, continuously. And once it sees that seizure, it sends an impulse to absolutely stop it, sort of get you out of the arrhythmia of the brain. And it's really an amazing device, and really is helping children that we can't sort of take out their language centers. We don't want to take out their motor center. We don't want to give them a deficit that is just not tolerable. And this device allows us to keep that brain tissue that's very eloquent or functional, and allows us to really alter their epilepsy to really manage it. This is one of our first patients that we did, his 3D model. We were able to implant one of those devices and really dramatically cure his seizures, where he's not having any clinical seizures during the day anymore, and only has these like auras that are sort of the device going off. Really amazing technology, really amazing advancements, and really just a pleasure to do, because these are patients that were having multiple seizures a day. Their life has sort of been ruined by those seizures, and really rewarding experience to be able to give those children back to their parents in a much more functional state. We also do a lot of pediatric neurosurgical trauma. Pediatric neurosurgeons operate on the spine, the brain for trauma. This is a OC dislocation. This is a fusion operation where you can see a screw here is placed into the C2 vertebral body. You can see then there's a rod, and then that is at the occiput. We also decompress sometimes, and we lay bone graft. You can see we went from electrodes all the way to hardware, titanium hardware into the spine, You can see really that varied experience, and really another rewarding thing to be able to give a very traumatically injured child back to their parents that's going to do very well. You can see here a epidural hematoma with a skull fracture. You can see in the top left panel, the white area under the fracture is the epidural, is the intraparenchymal hematoma with a subdural. You can see here the bone fragments that are being pushed into the brain. Our curvy incision we do to prevent hair loss and to prevent the hair from giving apart, and us sort of putting the pieces of the puzzle back together, the Humpty Dumpty of the skull, sort of having to piece those pieces back together. This is also a very rewarding experience. Everywhere in the world, you're going to have trauma. That's one of the few parts of medicine that will never probably change. There's always going to be some trauma, and you're always going to need surgeons that are going to be able to do that. And pediatric surgeon really is one of the great aspects of our lives that we're able to do that. This is a baby that was hurt by a dog in the teeth of the dog, and we were able to repair the brain, repair the covering of the brain, repair the skull and the incision to really give that family back their little baby. You can see here in the top two panels a bullet. This is a bullet near the spinal cord. This is a bullet lodged into the spinal cord, into the thecal sac. We see some very unfortunate things that we can help, and we see sometimes very unfortunate things that we can't. Unfortunately, this is a boy that became quadriplegic from that bullet wound. And this is at the bottom panel, you can see a gunshot to the head. This was a self-inflicted suicide that is not survivable. You can see sometimes we're able to return those kids back, but there's also another aspect of our lives where we're actually just dealing with the families and really trying to help them cope with what a situation becomes. To a brighter side, we'll switch over to pediatric skull anomalies. This is a really very cosmetic aspect of what we do. There is actually brain pressure, and there's also brain growth that goes along with this. But you can see here in the center panel, this is the normocephalic brain. This is the sutures that we talk about. In pediatric neurosurgery, the front suture is called the metopic suture, the coronal sutures, the sagittal sutures, and the lambdoid sutures. You can have different aspects of these sutures closing because of different molecular signaling. And that molecular signaling can really alter the shape of the skull and can cause some major deformities. Those deformities can make kids look really funny. And they can get made fun of. They can really develop their brain differently. So we try to fix those early on in life where it actually can be fixable. You can see here in the top left is a sagittal synostosis. The sagittal suture has closed too early and creates this very elongated skull. You can see here in the middle panel on the left, a metopic synostosis. This is trigoncephaly. This creates this triangle forehead that is very abnormal looking. You have bilateral coronal synostosis that gives you a very broad forehead. You can also have unilateral coronal synostosis that gives you an eye that's looking up, looking a very surprised look. You can then have lambdoid synostosis that gives you sort of a flattening in the back and a pointed side part of the head. The number one thing, though, that we actually do see is not even craniosynostosis. It's actually called deformational plagiocephaly. And this is because it's a back to sleep program, sort of to prevent SIDS. And to prevent SIDS, that sudden infant death syndrome, we have kids sleep on their back. We don't have them sleep on their stomachs. And by sleeping on the back, that can cause pressure at night when kids are wrapped too tightly or when they're positioned the same way, so that it causes a very flattening of the head. That is the number one thing we see in the office for these skull anomalies, which is totally cosmetic. There is nothing wrong with the brain. And we're able to put them in helmets, or we're able to do position changes at night in order to get a more rounded shape. This is a video of sagittal synostosis. You can see here the skull. We'll play that one again. You can see the skull is very elongated, like a Mr. Peanut sort of shape. You can then see that there is a big ridge on the top of the head that's causing that elongation, and a very big occiput and some frontal bossing, we call it. We used to do these big open procedures where we actually would take off huge portions of the skull. We would drill away all those portions of the skull and then plate it back together for late craniosynostosis, or just leave it off and the bone would grow back for early. We now do a lot of endoscopic procedures using a camera, and we drill off just the suture, and then we use helmets in order to really reform that head. This is a very rewarding operation because these children live a totally normal life. They look absolutely normal. All their hair grows back, and really a cosmetically great outcome. You can see here coronal synostosis, unilateral. You can see here the raised eye on the child's left eye in the left panel, looking at that very surprised look. Here is a video of that. You can see here that raised eye here on the left. That orbit is totally different than the other side, and that's because this suture has been closing. And again, we do this now minimally invasively with a little tiny incision and a little camera, but you can also do that later in life, usually at 9 months of age with a much bigger incision. This is what we were talking about from ectopic synostosis. This is that trigonencephaly, this very triangular shape of the head. You can see here on the CAT scan that pointed forehead, the fusion of that too soon. You can see here, this is a later procedure. This is one that was not done endoscopically, big incision, that wavy incision again, so the hair grows and doesn't cause a part. This is sometimes a very big blood loss operation that needs a blood transfusion. If we get them earlier than 4 months, we're able to do that usually without a blood transfusion. And really, we've sort of changed the whole dynamic of the post-op recovery by using these small cameras and small incisions if we do them before 4 months of age. This is taking off that front plate of bone. You can see here on the left panel, that huge ridge that's underneath that was causing that triangular shape. We then cut that in half. We reform the skull into different portions to make it much more of a broad forehead. This bottom right panel is called the bandeau. That is essentially the orbital rims we put back together and we space out because the forehead becomes too pinched together in this syndrome. And these are absorbable plates that we use to plate them back that will dissolve over the next 2 years from the body. This is called a dermoid. This is another skull abnormality. This is essentially trapped skin cells in the skull or in the periosteum. When the baby is born, this can grow tremendously and actually erode into the skull later in life. It's not exponential growth like a tumor, but linear growth of sort of skin cells. You can see here it's cut open on the back table. We don't want to let this skin contents in because they can recur then. You can see here on the CAT scan, the sagittal CAT scan, how that dermoid has eroded into the bone. Not cancer, not a tumor, but just deformationally eroding into the bone there. And we take these out usually pretty early in life when it's very, very easy. A quick 15-minute procedure essentially is a cure. We don't even need to follow them unless it gets ruptured. This is a video of a giant dermoid coming out. You can see here that white, that glistening, we're really making sure not to rupture it. That bone has been really deformed, but can form back after taking this out. You can see it's totally encapsulated. We haven't ruptured it. Play that one more time. You can see here, the attachment usually is at a suture. And if we get the attachment, we drill that bone down, we really cure these because there's no more tissue to grow. But if we let these little tiny ones grow big, they become craters. Switching now over to congenital brain abnormalities. This is a Chiari malformation. You can see here on the left panel, at the bottom, the cerebellum is pushed down, peg-like. That then is causing a syrinx in the cervical spinal cord. The black area in the spinal cord is fluid building up. This has been treated in multiple ways. Now, if we can, we do a more minimally invasive procedure where we just remove the bone and we score the dura. That dura sort of is able to expand back and let the fluid go around the brain that needs to go. Traditionally, though, if we have to, when we have a big syrinx, we can open the dura, we can actually suture in a patch graft, allowing the cerebral spinal fluid, the CSF, to go around the cerebellum. This procedure is very rewarding because a lot of these patients report really severe headaches, arm pain. They can have numbness and tingling in their arms, their legs. And after the procedure, the headaches are eliminated. They regain most of their function, and usually it's a cure. One of the biggest things a pediatric neurosurgeon deals with is hydrocephalus. Hydrocephalus, really the buildup of cerebral spinal fluid inside the cavities of the brain, the ventricles, which may cause increased pressure of the skull. This is traditionally what is one of the #1 things that pediatric neurosurgeons do. You will see this all over the large head in babies. Usually the production of CSF per day equals the resorption. However, that is the happy balance. When one of those alters, if we can't absorb it, or we produce too much, that alters it, and we get a big head, we get enlarged ventricles, and eventually we get really this term hydrocephalus. There's 3 main types of hydrocephalus. One is non-communicating or blockage. That's usually blocked by a tumor or scar tissue. There's communicating hydrocephalus. Usually that's an absorption problem from either infection, from blood, or also from tumor cells clogging up sort of the pathways. We also have this other thing in adults called normal pressure hydrocephalus, that the pressure is actually normal, but they're becoming sort of altered mentally, walking wise and urinating wise because of enlargement. It's very unclear what causes that, but we do have treatments for it. This is the traditional baby that you will see all over the world that has hydrocephalus, born with maybe a germinal matrix hemorrhage, with an infection, very large head, looks much larger the head than the face. These sutures that we were talking about earlier become splayed. We have what's called an anterior fontanelle, the soft spot in the front of middle of the head that becomes bulging, and the sutures are splaying. Traditionally, the treatment for this has been a shunt. And we place, using a GPS system, a catheter into the brain, not that it needs to be with the GPS, but a catheter in the brain that goes to a valve that regulates how much fluid we take off the brain, and that then is placed with a tube into the peritoneal cavity, and that absorbs, that surface area absorbs the CSF. This is essentially plumbing. We are plumbers of the brain, plumbers of the fluid. This is the silastic tubing that goes into the ventricle. These are some of the valves that we use. In a lot of the developing nations, we don't have programmable valves. In the United States, obviously, we use a lot of the programmable valves, so we can really regulate exactly with magnets how much CSF comes out per day, based on the pressure and based on the production. That way we can really fine tune it not to cause other side effects. But this tubing essentially then keeps that child alive for the rest of their life. It sometimes has to be fixed, it sometimes clogs, but we keep them alive and doing nearly everything they would ever do, just based on this tubing draining that fluid into a different space. But it's plumbing, and it is frustrating at times. It can block, clog, and just like a car needs to be fixed every once in a while. But can also still be very rewarding because these families have a child that's born or develops later in life a disease that can be life-threatening, and you really are able to keep them alive and have an amazing functional life. We have 3 different sort of main types of shunts. One is the VP shunt, where we actually put the tubing into the belly, the peritoneal cavity, for absorption. The second is a VA shunt, where we actually take the tubing and we put it into either the subclavian or the internal jugular vein, and then that gets passed into the atrium of the heart in order to absorb into the blood. Then we also have a V-pleural shunt, a ventricular pleural shunt, where we actually go into the pleural cavity, and the pleural cavity is actually what absorbs the CSF, the surface area of the pleural cavity. These are our three main ways that we shunt children, and really the body's normal absorptive process of a large surface area can take care of that excess brain fluid. This is an alternate approach. So when we have a blockage, we can actually do a procedure with a camera inside the ventricle, and that camera and hole can actually go around the blockage. So this is what's called an ETV, or endoscopic third ventriculostomy. This you can see here is large ventricles. This is the ravages of hydrocephalus. This is the septum pellucidum. This is the choroid plexus. I'm going to pause that for 1 second, go back. So here in this MRI, you can see the black areas are big, large ventricles, water building up, but we have a very small posterior fossa, fourth ventricle. The clog is what we call the aqueduct of Sylvius. That clog needs to be sort of altered. We can either unclog it at that site, which is really not safe. That's what some people tried in the past, but you can hurt someone that way. We actually do it at the bottom of what's called the third ventricle, just in front of the prepontine cistern near the basilar artery. You can see here, this is a septum, the part that looks like it's tissue paper that's been torn because the hydrocephalus, the pressure has built up and actually altered the brain. You can see then this big hole here is called the foramen of Monroe. The red stuff in that hole is choroid plexus. In the distance of that hole, you can see the mammillary bodies and the basilar artery. You can see us then here navigate down into that foramen. You can see this doesn't want to cooperate. You can see here that foramen. You can see the choroid plexus. You can see us then navigate down into that foramen, past the choroid plexus that's producing the CSF. You can then see here the basilar artery here in the middle. You can see at the base, the mammillary bodies, a very thinned out floor of the third ventricle. This red dot here in the middle is the infundibular recess near the pituitary gland. And we're going to place a hole to let the fluid go around this area that's getting blocked. Oof, does not want to cooperate. So navigating down to the third ventricle, you can see this floor of the third ventricle flopping away, and we need to place a hole. We take a balloon catheter. We make a small hole at first. We then expand that hole with graspers. You can see here the white webbing is arachnoid, another layer. We then expand it again with our balloon to get through all those layers. We then navigate the camera down to make sure that there's no other holes that we need to make. This is a balloon again, and you can see now the fluid flowing in and out of that prepontine cistern. The basilar artery is right there, the back of the clivus. And this is going to allow fluid, let's see if we can solve it right here, to go down that hole and go around the blockage. You can see here again the dilation. Looking down through there, you can see fluid easily is going to be able to get around all those little adhesions, making sure this hole is big enough so it never closes over. And now there is no shunt. There's nothing that needs to be fixed in the future. And we've sort of cured this child of their hydrocephalus. Another thing that's really big all over the world, usually from folate, not always from folate though, is spina bifida. This is what's called an open spinal cord defect. This is a myelomeningocele. This is when a baby's born, the spinal cord has not closed over. This is coming through the skin, and we need to close this in order to prevent what's called meningitis or infection, and also brain fluid, CSF leaking. This is usually closed within the first 2 days of the child's life. You can see here the big closure on the right. In order to recapitulate, the spinal cord and close over that skin area. A lot of these babies also have wiring problems. They sort of malform their brain because of this. There's also some centers that do this in utero, where we actually go inside the uterus at a certain amount of weeks in order to close this over. That has a whole other different aspect to it. But this is sort of caring for these patients. And this is a very common thing all over the world. This is why mothers that are pregnant supplement with folate in order to prevent a certain percentage of these that are going to be a folate deficiency. This is another one you can see here that has bulging of the membranes, and the CSF is built up underneath that spinal cord. You can see here, this is what we call the placode, is the red part in the middle, the skin that's covering around it. And our goal is to close this over to not have brain fluid leaking out, and also not to have meningitis or infection form because of this open into the spinal cord. You get a lot of leg deformities due to this because those nerves are not accurate. They're sort of not formed correctly. You can see here the leg deformities, the club foot. A lot of these children, if the level is high, are not going to walk. They're going to be in wheelchairs, non-ambulators, but they still need to be closed. Otherwise, they will die of meningitis. This is the closure that we're trying to get. We're trying to close the spinal cord. We're trying to close the covering of the brain. We're trying to close portions of the fascia and also the skin in order to allow these children to really live the best life that they possibly can, even though some of the leg deformities are never going to be corrected, or the deformity will be corrected, but the functional status won't be. This is what we call a cystocele. This is just the fluid building up. There is also some aspect of neural tissue here, but this is a skin covered. This is a different defect in embryology, where actually it's completely skin covered. You can see here the transillumination of that, where all the CSF you can see here. With transillumination, you can see here on the right panel, this opened up the sac of fluid that we need to close, the different layers that we need to get closed in order to have this child look normal. But very rewarding congenital anomalies that we do in the spine that really are not taken care of by much other neurosurgeons or other aspects of the community, because this is very specific to pediatric neurosurgery. Scoliosis is also becoming a big portion of what we do. We do tetherings. We do the actual scoliosis procedure. We have hemivertebrae that we resect and take care of, and spinal fusions like you see here, the metal implants that you see on the right. Another aspect of pediatric neurosurgery that's really coming into vogue at this point. Scoliosis also has a congenital aspect to it, where we put in growth rods. These are magic rods that have a magnet that actually distract to allow the scoliosis not to get worse, but to let the rib cage essentially get bigger. Because if you fuse kids too early, you're going to really decrease their pulmonary function, and we really try to get them a little bit older. We are going to then switch over, we're running out a little bit of time, to brain malformations. This is a pediatric vascular malformation called an AVM, arteriovenous malformations. There's also dural AV fistulas that we deal with. This one has been embolized. You can see here on the left panel, this is the AVM or cavernoma in one of these children. And this is on the right panel, an AVM on the surface of the brain. This is the dura that's been opened up and sutured back. You can see the black greenish material is called onyx. That's an embolization material that we try to put in there to make it safer through an angiogram preoperatively. And our goal here is to take out the AVM tissue, but leave all of the normal brain tissue. These can be extremely bloody operations if they're not planned well, but very rewarding, because these can cause seizures, these can cause brain bleeds, these can be life-threatening. A lot of people that rupture these don't actually even make it to the hospital. We also go on to pediatric nerve conditions such as brachial plexus injuries. Those are birth injuries from like shoulder dystocia. The number one cause of that is like maternal diabetes, too large of a baby. We also do nerve sheath tumors in children. This is a schwannoma in the middle panna, a large schwannoma tumor. And we also do, when you do have birth injuries, not just brachial plexus lysis or brachial plexus explorations, we actually also transpose vessels nerves in order to recreate some of the function. You can see this is a classic Erb's palsy from a birth injury. You can see the down out arm. You can see the little baby not being able to reach it up. And we actually have procedures where we take nerves that are functional, split them in half or thirds, and we actually bring them to other nerves to sort of refunction the arm. A huge aspect of my life is also the residency training here. Northwell has a huge residency training, one of the biggest in the country, and it's ever growing. And this is the Hofstra resident education. We run anatomy labs, we run surgical procedures. We have residents getting taught in the operating room. This is a part of neurosurgery and pediatric neurosurgery that I absolutely love. Why we're here for the brain turns is because this is such a rewarding experience, sort of passing that knowledge down through sort of the ranks, and really a huge aspect of what we do for pediatric neurosurgery, because pediatric neurosurgery doesn't usually happen at community hospitals. You really need big university hospitals in order to do it. And that comes with residents, which I really, really enjoy that aspect of my work. We also have a lot of community outreach. We do a hydrocephalus walk, we do epilepsy walks, we raise money for different brain tumor foundations. This is also another really fun aspect that I like doing, is the community outreach. These are big families that really care about their children, care about us, and it's really fun to see them outside the hospital. Hopefully that was a whirlwind tour, and really seeing a lot of the aspects of what we do in pediatric neurosurgery. Each topic could go on for a whole nother hour by itself, but hopefully that was a little bit of a whirlwind, and I left plenty of time, hopefully, for questions and transition. I thank you guys all for showing up for this, and really, this was a shout out for Randy. One temporary tattoo to compete with his little bit of his artwork there. But thank you all, and hopefully you enjoyed. I will open the chat. Maybe I will stop sharing, and then I am going to open that chat. Okay, I'm going back. So, to earn a certificate, no, that's certificate, recorded sessions. We are posting these on YouTube. The last few have been posted. They will eventually, I'm sure, get onto YouTube. More is pediatric, more mentally taxing. I think people that go into pediatrics really like the aspect of the children, the family, the parent interaction. There is some people that shy away from that and don't want to deal with that aspect of it. I really enjoy the pediatric aspect, and I think it really, it sort of self-selects people that want to do that. Does scoliosis have to be invasive procedure? There is actually tethering procedures that are much more minimally invasive. It does not always have to be huge invasive procedures, but a lot of them are. There is minimally invasive. We also brace a lot of children. A lot of children are getting braced. It's not really until you get to about a 40-degree scoliosis that really they need surgery. Some kids actually can get through even with just bracing. Scoliosis can cause a lot of deformities in the spine, can cause pain, muscle problems, hip problems. Scoliosis really has a huge aspect throughout the entire body. How many seizures do these patients have to receive this stimulator device? They could be having just even a few a year, and this device can go in. but usually the device is going in because it's an area we can't burn, we can't resect, we can't take out. How many different subspecialties of neurosurgery can a single neurosurgeon work on? For pediatrics, we work on a lot. A lot of the other surgeons maybe focus on 1, 2, 3 areas. Usually you pick one of those that you're really interested in the research aspect, you're really interested in the surgery aspect of it. A lot of people make the big distinction between spine versus brain, cranial neurosurgery. The risk factors of the NeuroPace device, that brain stimulator device, is really infection is the number one. There's not much other things. Obviously, seizures with it, but there's really not that many other risks to it except an open operation. Are there any pediatric neurosurgery procedures which you traditionally perform more often or specialize in? So hydrocephalus is clearly one of the biggest. Craniosynostosis is a large one. Spina bifida, brain tumors, epilepsy, trauma. Those are probably the biggest. Are fatalities more prevalent in pediatric neurosurgery? I would say we cure brain tumors in pediatrics about 75% of the time. Adult tumors, for meningiomas, there's a lot of curing, but for GBMs, there's not a lot of curing. So depending on the tumor biology, but it is very rewarding in the patients in the pediatric space because we cure a lot of the brain tumors. Very rewarding, very curable. And a lot of those cures are based on the surgical skill, which is even more rewarding for the surgeon. What causes the formation of dermoid? It's sort of trapped skin cells that grow just during birth. A lot of CAT scans, MRIs are routinely done. We try to avoid some radiation by doing more MRIs now in children. Age limit for placing a shunt. There is no age limit. We place them in 80-year-olds for normal pressure hydrocephalus. We place them in 1-day-olds. Usually we don't place shunts in patients that are less than 2 kilograms because there's a much bigger complication rate. We usually will tap or place needles into the ventricle and draw fluid routinely before we shunt them until they're about 2 kilograms. Are the same treatments used to treat adult hydrocephalus? Yes, there is shunts that we put in for adults. There's ETVs that we do. Does in utero have a higher or lower mortality rate? In utero repair of a spina bifida has a high mortality, doesn't have a high mortality rate, but does have a slightly higher one. The shunt, we don't place in utero, but hydrocephalus in utero has much more cognitive issues. Which cases do you consider for ETV? There's actually a scoring system for ETV. I do them a lot in myelomeningocele, aqueductal stenosis, less so in intracranial hemorrhage, such as dermal matrix hemorrhage, occasionally an infection. Is it better to do in vitro closure of spina bifida? A lot of people would argue that you can save a level or save some function. I think this is still up for debate, but there is definitely some major centers doing in utero closures. It definitely can help patients in different ways, but you have to be a candidate for that. Can hydrocephalus be treated by removing some of the choroid plexus? It can in certain ways, usually with an ETV, but it's impossible to cut out or coagulate all the choroid plexus. It's always going to grow a little bit, always going to produce some CSF. But yes, you can take some of it out to help reduce the burden. What equipment is used for transillumination? That was just a regular flashlight. That was a normal pen light that you would normally have in your white coat. Fluorescein we use for endonasal procedures to look for CSF light. Not in that transillumination one. Is pediatric neurosurgery residency its own thing? It is a fellowship after neurosurgery. It's not enfolded. It is completely 1 year after you complete an American neurosurgery residency. Other countries, it's also a fellowship afterwards, but a little varied on when you do it. Can you talk a little bit more about nerve splitting? It's a procedure where we essentially take a normal nerve, a robust normal nerve, we split it into different fascicles, and then we can cut those fascicles and transfer them into a different nerve, more distal nerve of a problem nerve that's been damaged more proximally and sort of split into it. That's also a whole nother lecture. repair the skull, so plastic skull is much better in adults. We use a lot more of the patient's natural bone in kids because they can grow that bone back a lot easier. For almost all of these craniosynostosis that are in 1 year of life, that bone completely grows back. You can take out essentially all the bone up above the ears, and all that bone will grow back in a child that's less than 1. What drove me to pediatrics neurosurgery is really the brain tumors, the epilepsy, and the surgeries that I really enjoy doing. And I also really enjoy a very varied practice. I didn't want to do the same thing. Like orthopedics, I did not want to do 4 hip surgeries in the same day that were pretty identical. You guys are all welcome for this lecture. It's been really a pleasure. If you want to private message me about different residencies and fellowships, that's more than no problem. The very common tumors that we see in kids in the posterior fossa are medulloblastomas. We see ependymomas. We see low-grade tumors. Going through, I think we are about, oh no, 37 more messages. It's always a huge challenge to get through all these. When did you know I wanted to go into pediatrics? It was about my 4th year of residency. In a 7-year residency, I really knew that's what I wanted. Challenges as a pediatric neurosurgeon. Clearly there's some challenges dealing with young kids, dealing with families, dealing with a system that really, as these kids grow, you want to still take care of them. And I also do some adult neurosurgery. I'm not going to touch neurosurgery versus neurology. DIPG tumors, there is some development, especially on the molecular pathways and diagnosing them. There is definitely radiation, there is convection therapy, there is catheters being put in. I enjoy pediatric neurosurgery. It's not for everyone, but I'm not going to say if it's better. There is a vagus nerve stimulator that's different than the responsive neurostimulator. That's a stimulator that goes onto the vagus nerve to help reduce the seizures. That's not going to cure seizures, but can reduce the burden. Shunts are a lot of the go-to treatments for intracranial hypertension. However, we do also venous sinus stenting if there is a direct venous stenosis that has a gradient that's done by the interventional neuroradiologist or neurosurgeons. Usually obstructive hydrocephalus versus communicating hydrocephalus is the reason we choose ETV, or a few other reasons. I think I made it. And then there's some COVID stuff. We definitely stopped doing surgeries during COVID, all elective stuff. And we volunteered in the adult ICU and did normal COVID stuff, just like everyone else, I think, in the whole world. And I am so thankful to be sort of getting out of that world. Thank you, everyone. I really appreciate it. I am on the web. I'm on Instagram. I am on Facebook. There is professional pages out there for me. If you want to contact me, it is a pleasure talking to you guys, and really any part of your journey that you're there for. Hopefully this was a highlight of sort of a learning experience.
Yes, that was amazing. Thank you so much, Dr. Rodgers, for your time. And I know everyone saying thank you in the chat. Yeah, that was great. Thank you.
You are all very welcome. Have a wonderful day. Enjoy the rest of the lectures.